the question was then, can we design a study to assess both the frequency of MOG-IgA as well as its associated clinical phenotypes in patients with central nervous system demyelination. And to do that, we set up a study, as I said, by the way we discovered it, it was set up in a discovery and confirmation setup. So we had an initial cohort of 300 and 305 patients from the University of Basel, and then the joint cohorts from the other center were 1,039 patients. So we had a total of 1,344 patients with central nervous system demyelination that we screened for MOG-IgA, IgG, and IgM. As I mentioned before, we had prior to that developed a live cell-based assay expressing full-length human MOG that allows us to measure MOG-IgA responses in parallel to IgG and IgM responses in the serum. And so when we looked at, this cohort of 1,344 patients in terms of clinical phenotypes, there was a group of patients with NMOSD that were fulfilling Wingerchuk 2015 criteria. We had MS fulfilling McDonald criteria, and we had a decent group of patients that had what we call other demyelinating disease phenotypes that would formally neither classify as NMOSD or MS. And so we then basically set up screening these patients, 1,344 patients, for the presence of MOG-IgA, IgG, and IgM. And we also had a cohort of 110 healthy controls that we screened as well. And when we did that, we identified 18 of these patients with isolated MOG-IgA antibodies, but none of the healthy controls harbored the antibodies. In addition to other patients actually harboring both MOG-IgG and IgM or IgM antibodies. But we are now focusing really on the patient that are isolated IgA from the rationale that from a clinical perspective, right, we have this big part of patients that are seronegative for any of the two antibodies, so ACOPON4 and MOG-IgG, and we are kind of hoping to help stratify that. So that then prompted us to say, okay, we have those 18 patients with isolated MOG-IgA. How do they look clinically when we look at them? And based on the study design, we had 3 clinical phenotypes, NMOSD, MS, and other demyelinating diseases. And from the cohort we screened, we found that patients with MOG-IgA, when found in 6% of the double seronegative patients with NMOSD, in I think I'll have to look up the exact numbers now as we speak, in about 2% of other demyelinating MS diseases and 1% of the MS patients, clinical phenotypes. And so there's clearly a strong association to an NMOSD phenotype. And then when we really hone in on the concrete clinical phenotypes and contrasting MOG-IgA patients to patients that had MOG-IgG either isolated or in coexistence, because the current gold standard is, right, we just check for MOG-IgG and we don't know if they have another IgG or IgA or IgM coexisting. We found that the most frequent disease manifestation in MOG-IgA patients was myelitis followed by brainstem syndrome, and less frequently ON compared to MOG-IgG. And what was quite interesting, because we had a big MS cohort with more than 800 MS patients from our center, the 38% of the MOG-IgA patients that had a confirmed MS diagnosis actually carried type 2 oligoclonal bands, which is typical for MS, which were, of course, now then much less frequent in these MOG-IgA compared to the double seronegative patients with MS but no MOG-IgA. So that also clinically shows that there are features in those patients harboring a diagnosis of MS that are not typical for MS once they have the MOG-IgA antibody, which I think consolidates the fact that there seems to be a specific clinical phenotype that seems to be rather overlapping with core clinical features of NMOSD and MOGA than multiple sclerosis in patients with MOG-IgA.